All right.
That's me. Okay. So I want to talk about the America's Children and the Environment project, which I've been managing for EPA. There's the websites there, epa.gov/ACE, where you can find all the details. And what we're looking at is measures of and indicators of children's environmental health. And we summarize the available data, we look at trends, we look at demographic differences, and we have various indicators that we're looking at in three groups. First of all, we look at exposure. We look at air pollution, drinking water exposure, pesticides in food, contaminated lands. That's the percentage of children living close to a hazardous waste site. So looking at children's exposures to environmental contaminants. Then another set of measures we're looking at is to do with biomonitoring data, essentially dose, but there's a translation between the biomonitoring data and the actual dose, which is non-trivial. But we're looking at concentrations in both women of childbearing age and also children for lead, mercury, cotinine, phthalates, BPA, perchlorate. There's the list up there. So summarizing trends and demographic differences in their in the concentrations. And then the third set of measures is to do with the health outcomes for children. The percentage of children nationwide that have current or asthma, other respiratory diseases, cancer, neurodevelopmental diseases like learning disabilities or ADHD, obesity, of adverse birth outcomes. So the outcomes of the environmental exposures. So the report that is at that website summarizes the trends and some of the demographic differences for different groups of children. But one interesting thing that we do is we're often interested in exposures, in utero exposures, and for the biomonitoring data, what we have is data on women of childbearing age. And one sort of novel idea that we've applied is to adjust for the fact that younger women are more likely to get pregnant. There's more births to younger women than older women. So in order to estimate in utero effects, we re-weight the data from the NHANES study based on the proportion of women or proportion of births to women of different age groups or different races and ethnicities. So I think that's a useful idea of estimating in utero exposures, potential in utero exposures, when all you have is data on children, on women of childbearing age.
Thank you. Now, let me get this.
Okay, so you press the green button, right?
Yeah, the top one. Yeah.
Okay.
You're next.
Okay, so that's me. So my work really occurs at the intersection of environmental exposures, social disadvantage, and health disparities, both understanding pathways of intersection, but also identifying new pathways to prevention. And my work, the research questions I ask roughly fall into 4 categories. One is identifying sources of exposure to these chemicals. So as evidence accumulates about the adverse health effects of some of these chemicals, such as phthalates and flame retardants, increasingly regulatory, authoritative, clinical bodies are recommending exposure reduction, but clearly there are few options available to people like pregnant women on how to actually reduce their exposure. So it's very important to identify modifiable sources. Last week, I actually had a new paper come out showing that fast food intake may increase exposure, population exposure to high molecular weight phthalates. And this was actually done leveraging the same data set that Dr. Cohen spoke about, the NHANES. And NHANES has really been an invaluable data source to the environmental community because it's roughly representative of the US population and really has a wealth of information on exposures, health outcomes, and other medical and health characteristics. Another area of my research is really focuses on advancing exposure assessment during pregnancy and early development. Dr. Birnbaum very convincingly discussed the importance of this vulnerable period of development. So it really, our understanding of exposures during this time will really help our evaluation of health risk. So in both looking at how chemicals partition across the maternal fetal unit during various points in pregnancy, including looking at pregnancy tissues, placenta, and also starting to develop new methods to characterize cumulative exposures. We increasingly know that we must do a better job of accounting for the chemical soup. And in terms of even looking at vulnerable populations, those people who may have, that have the cumulative burden may be different than people who have higher exposures to one or two chemicals. So really, we need better methods for looking at chemical mixtures and cumulative burdens. Another area of my research involves using analytical methods to understand the intersection of chronic psychosocial stress and environmental chemicals, because socially disadvantaged communities often experience a higher burden to both of these. So I look at both biomarkers of early response, such as telomere regulation during pregnancy, as well as overt health outcomes like pregnancy complications. And lastly, because we all ultimately want to improve public health, I think it's important to evaluate the regulatory and policy actions that have taken place, and to evaluate the impact of these measures on exposure and health reductions. And once again, I've leveraged the NHANES data sets, for example, to show how NGO activity as well as federal regulations have changed Americans' exposures to phthalates, albeit it has led to the rise of problematic substitutes, which is another reoccurring problem in our quest for better environmental health. So I'll leave it at that.
Thanks.
So I'm just going to briefly describe two studies that we've been involved in. These are studies that recruited women during pregnancy, and we modified the intrauterine environment and then followed the offspring out to see the impact that those changes had on offspring health. So this first study is a consortium. It's an ongoing consortium of 7 randomized controlled trials of lifestyle intervention versus enhanced standard of care in women with overweight or obesity. So this is an ongoing collaboration. We just finished recruitment in December of this past year, with our last deliveries expected this summer. And then we'll be following the children out to 1 year. The goals of these trials are to reduce excessive gestational weight gain. So both preconception obesity and excessive gestational weight gain are established risk factors for childhood obesity. So we are attempting to stop that cycle. And so in this study, these cohorts are racially and ethnically diverse. About half of the cohort has reached their 1-year follow-up, and so far we have very good follow-up of our children. So the study, as designed, is funded to follow the children through the age of 1, both the mothers and the children through the age of 1. Focusing on the child outcomes, we are looking at body composition, so we're measuring weight, length, and skin folds. Now, recent data has suggested that the prenatal effects may not become evident until the age of 2 or later. And so we understand that we need to have a longer-term follow-up. And so we have submitted funding to follow these children through the age of 7. And this would include the measurements that we completed at birth and at 1 year. So that would be the weight, height, skin folds, and then also adding more sophisticated measures of body composition, so air displacement plasmography and MRI to get a better estimate of body fat. We are also going to be measuring cardiometabolic factors, obviously given the relationship of those with obesity, and looking to see if there is an impact of lifestyle intervention administered prenatally on infant health. So the second study was recently completed, and these studies came about in the late 1990s. There were studies that were published that showed women that had elevated TSH or were classified as hypothyroxanemia during pregnancy, their offspring resulted in a lower IQ. So in the late 1990s, this resulted in many professional organizations endorsing the screening and the treatment of pregnant women for subclinical thyroid disease. And so what we wanted to do was to design studies to really evaluate this impact on child health. And so 2 parallel randomized controlled trials were conducted. The first one among women diagnosed with subclinical hypothyroidism, and the second one among women diagnosed with hypothyroxanemia. They were randomized to either thyroxine or placebo, and the infants were followed for 5 years. These results were just published in February of this year, actually presented in February this year at the Society for Maternal Fetal Medicine. And the studies found that there were no differences in neurodevelopmental testing that was conducted annually, but most importantly, that there was no difference in IQ at age 5. Further, there was no difference in behavioral testing, including ADHD, that was assessed at year 4. So these studies show that that treatment of subclinical hypothyroidism and hypothyroxanemia is not warranted. It did not improve cognition or behavioral measures in the offspring through the age of 5, and thus the screening of pregnant women for subclinical thyroid disease is also unwarranted.
Thank you very much. I think that one of the things that I find interesting about these examples is the applicability of this kind of research to real-world decisions, whether it is standards of care for medicine and obstetrical care in particular, which we don't deliver perfectly well in this country. I think many people in the audience are aware of that, or whether it's environmental regulation and an agency like the EPA being able to actually monitor whether the regulatory system is producing the results that it's trying to produce by looking at the trends or not, or to actually be able to understand which chemicals need to be regulated in the future and whether our regulation is actually wise in terms of targeting the right compounds, the right things to regulate.